Hello everybody, here's a new ISGE podcast. You'll hear an interview of Professor van Herendal produced on the ISGE conference in Cape Town in spring 2019. Bruno van Herendal is one of the most famous hysteroscopists all over the world. Professor van Herendal, what is the most important step planning a hysteroscopic myomectomy?
I think that one of the most important, or the most important thing when we talk about hysteroscopic myoma surgery is actually the preoperative evaluation, like we do it also for the for what we do laparoscopically. We have to be sure and certain that the myoma is benign, and so we work together with the ultrasonographers, and actually we are now having a course on the combination between ultrasound and hysteroscopy, well done more or less at the same time, meaning first the diagnostic part and then the operative part. The second thing that we have to know is to know about the physiology of the uterus. That means that the fibroid is actually just another part of the muscle that is now submucous, and it's only the arrangement of the muscle fibers that is different macroscopically. There are differences, of course, but macroscopically. And so that fibroid creates a pseudocapsula, and that we have to stay or to confine ourselves when we operate as much as possible, as we do in laparoscopy, to treat the myoma inside the pseudocapsula so that we don't damage the rest of the myometrium. I believe that is the two main actually points of let's say interest in hysteroscopic surgery, that you have to master an endoscopic myomectomy by hysteroscope.
Yes, so I think the myomectomy is one for patients with bleeding disorders, but very important also for patients who have problems to get pregnant. So, what is the role of the micro hysteroscopy, the smaller scopes?
The thing is that for sure you do myomectomy. In principle, when a patient that is in a menopause or in a perimenopause has a fibroid, the hysterectomy is a better choice, because this is something that can recur, and so it's because it's just a muscle, and so that is the reason why most of these myomectomies are done in patients with fertility problems, because of course we are looking, when we do a hysteroscopy, we look at an artifact, because we blow the uterus up with our distension media, but if you then look at the impact of the fibroid on the myometrium, both on the myometrium over the myoma and the myometrium on the other side of the uterus, you see that the impact is quite great. On the other hand, of course, we would like to not to dilate the cervix too much, and so the tendency is to go for very small instruments, up to 15, 19 French, which is around between 3.5 and 5 millimeters, so that we can actually do the operations without dilatation of the cervix.
Professor van Herendal, thank you very much. We hope we will hear more in the future and be back on air later. Thank you.
Thank you very much.